I'll welcome Dr. Balaji Balakrishnan. Next presenter is Assistant Professor VAT Vellore. During his postdoc, he has worked on endothelial damage created by conditioning regimen, both in vitro and in vivo. Now he is going to present on endothelial activation and pancreatitis.
Thank you for the invitation. So this is going to be a general talk regarding endothelial activation in acute pancreatitis. Much of the introduction has already been discussed in the previous talks. So acute pancreatitis is a multifactorial condition with the most common causes being gallstones, alcohol use and hypertriglyceridemia, although we also have other less common causes and all, which I'm not going to discuss over here. But as a result of those toxins, what happens? They contribute to ATP depletion, resulting in elevated intracellular, intra-acinar calcium concentrations that trigger early activation of trypsinogen. And this cascade leads to a release of dams, triggering neutrophils, inflammatory responses happening, and this inflammation, when it intensifies, that becomes systemic, and then it leads to SIAS, MODS, and microvascular thrombosis and all. And acute pancreatitis is characterized by the spectrum of severity. In most cases are mild and self-limiting. However, 30% of the cases are classified as moderately severe and 10% as severe according to Atlanta classification. Organ failure is the main determinant of severity and the main cause of early mortality. When you see the pathophysiological event, foremost premature activation of trypsinogen to trypsin in the pancreatic SNS cells rather than the duct lumen, that leads to activation of the zymogen cascade, including the elastase and phospholipases, which is contributing to necrotic tissue that attracts the inflammasome towards it. And the components could be either trypsinogen autoactivation, cathepsin B mediated activation, which the previous speakers they focused on. And the molecular mechanism being the toxins increasing the lysosome productions, and they fuse with the zymogens, and then they'll try to release the cathepsin and mediate apoptosis or necrotic pathway. And it may also be because of intracellular calcium increase, and that increase could be because of release of the intracellular stored calcium reserves in the sarcoplasmic reticulum, or there will be modification in the exchanger proteins like ORA1 like this, so that it is increased. Because of this increase, it might lead to decrease in ATP, and further it may lead to a pathways towards apoptosis and necrosis as well. And these are the different compounds that are involved in this. And very recently it has also been noticed that there are misfolded proteins as a result of these toxins, which can elevate the AR stress response pathways, either PERK, IRE1 alpha or ATF6, that lead to global protein synthesis at innovation, and depending on the threshold of the damage, it may send the cells towards apoptosis or necrosis eventually. And again, those necrotic cells eventually will lead to attracting the inflammatory reactions, as you can see over here. It can show up the dams, and then it can lead to inflammasome activation of other components through NF-kappa B pathways and all. And of course, neutrophils mitosis happening, and as a result of it, it can also lead to ductal obstructions, and inflammasomes are finally activating and damaging the endothelial cells, which is what we'll be seeing in the subsequent slides. And this table shows a different inflammatory response, where you can see dams in the components involved in it, TLR activation in the components, inflammasome activation, and neutrophil infiltration as well. Now, when it comes to inflammation, irrespective of the causative factor, SNS injury is associated with early inflammatory reaction within the pancreas, and NF-kappa B mediated pathways are activated. The consequences being neutrophils and monocytes activated, exaggerating the damage in the gland, and in the endothelium, the consequences being vascular injury within the pancreas, and they are activated and they are injured, leading to increased vascular permeability and activation, and increased leukocyte rolling, etc. Now, when this inflammation intensifies and that becomes systemic, and that leads to systemic vascular leakage and finally damage to cardiovascular, kidney and lung failures and all. And systemic endothelial dysfunction may also manifest itself as diffuse activation of coagulation with clinically significant thrombotic complications as well. Now, they have normal endothelial cells, they function as a barrier between blood and the tissues, and they also control vascular pressure and permeability, activation and addition of platelets, etc. And they are a dynamic tissue, as you all know. They are important for hemostasis and inflammation as well. Now, healthy endothelium under resting conditions, they have anti-inflammatory and anti-thrombotic functions, but when they are activated by inflammatory factors, they tend to increased expression of addition molecules like VCAM, ICAM, selectins like E-selectin and P-selectin, and then it leads to increased addition of leukocytes and platelets, and of course transmigration of leukocytes through vascular wall. And the two main pathways are involved inside the endothelial cells towards these activation, which are VEGF binding to VEGF receptor or angiopoietins binding to Tie2 receptors. Now, in terms of endothelial barrier function, it is a tightly controlled function where it is mediated by intercellular junction proteins and tight junction proteins such as zonooccludins, occludins, claudins and all. Now, what happens during leukocyte extravasation? That time, VE carrying molecule between the endothelial cells, they become phosphorylated at a specific residue which is tyrosine 371. Whereas when inflammatory stimuli is there will be vascular leakage, and that is mediated by phosphorylation at a different residue which is tyrosine 685. Now, when a different residue is phosphorylated, that leads to formation of a more gap between the endothelial cells, and also it leads to the cytoskeleton remodeling of the endothelial cells. Now, because of that, the endothelial cells, they become so fragile, and as you can see in the last one, it leads to the vascular leakage. So, endothelial cell activation upon inflammatory stimuli such as VEGF or histamine, they induce vascular leakage leading to translocation of protein-rich plasma into the extracellular space. And if it is systemic, there will be ubiquitous loss of endothelial barrier function across different tissues. Right? So, there could be multiple stimuli which can do what we have seen over here. And overall, destabilization of vascular endothelium, increased vascular permeability, disrupted vasomotor regulation, and activated coagulation lead to early complications in acute pancreatitis. So we can use those markers which are specific for endothelial damage towards prediction of severity, complications, and mortality in acute pancreatitis, and that's what different groups were trying across different labs. As you can see in this table, you have angiopoietin, FLT1, E-selectin, ICAM1, thrombomodulin, all being used as single marker towards such prediction. This is one way that we can do. Out of this, angiopoietin is different groups are trying to validate angiopoietin across different settings because of increased sensitivity and specificity over here. Another approach is that using multiple markers and looking at the endothelial damage. Like here, they try to look for VWF ADAMTS13 axis. In endothelial cells, von Willebrand factors are synthesized and storage, and they exist as multimers in terms of low molecular weight, high molecular weight, intermediate molecular weight, and ultra large. Now, the thrombogenicity increases with the size. Under normal condition, the low and the intermediate molecular weight are present in the circulation, and they are constantly secreted. High molecular weight and ultra large are stored in the WP bodies inside endothelial cells. And the high molecular weight mediate platelet adhesion at the sites of vascular injury by binding to collagen, as Dr. Sukesh said. And ultra large molecular weight, they are not normally present in circulation but are released secondary to local inflammatory response. Okay. Now, both high and ultra, they are rapidly cleaved into small by ADAMTS13. Now, this study, they try to evaluate this axis by measuring ADAMTS13 activity, von Willebrand factor, collagen binding activity, and then von Willebrand factor antigen. They recruited 98 patients, and out of 98, 78 had no organ failure, whereas 20 had organ failures. Now, in those patients, they observed patients with organ failure, they had higher amount of von Willebrand factor CBA activity when compared to those without or transient organ failure. Similarly, ADAMTS13, it was lower in those patients AP with persistent organ failure. In terms of correlation with the clinical severity, the ADAMTS13 had a negative correlation with the clinical severity scores and the duration of the hospital stay as well. And so this could be a good marker towards predicting the persistent OF and all. This is one approach. So many groups across the world, they are trying to link inflammation and endothelium by taking inflammatory markers and trying to explore them in animal models also. So quickly I'll go through two studies. One study is where, a recent study where they try to use CARP protein. Now, CARP is a critical stress induced protein in inflammatory responses. They function as DAM, and it has been observed in other conditions like shock, sepsis, etc. Now, the role of CARP in AP-induced multiple organ injury is what this group tried to study. Initially, they measured CARP in AP patients, 119 patients with AP and 80 healthy controls. The mean CARP levels in control groups is 22.9 picogram, whereas in AP it is 65. And in different aggravation of the disease, they are seeing increase in the amount of CARP. So the same thing we want to observe in the model. So in mouse model, they induced L-arginine-induced mouse model. They tried to look for CARP protein in different tissues, including pancreas, through Western blot, as well as through immunofluorescence, where they are able to observe the CRP increase after acute pancreatitis. And after which they try to look for microvascular permeability by injecting Evans blue assay. Now they are seeing more amount of vascular leakage in acute pancreatitis, enlargement-induced acute pancreatitis, and they also try to observe the same in knockout mice where CRP is not there, where the leakage is significantly mitigated. And similarly, they try to observe the same phenomenon across different tissues, pulmonary, intestine, hepatic edema, and AP mouse, in other tissues as well. Right? And they try to use an inhibitor which is C23 towards it. When they use an inhibitor, again it is mitigating the CRP-induced pancreatitis node. In order to know how it is actually performing functioning in terms of endothelial cells, they try to grow HUVEC endothelial cells and treat them with CRP peptide and try to look for transendothelial electrical resistance, which is drastically reduced over here. Apart from this, they also observed the actin remodeling and lower amount of expression of E-catenin and beta-catenin. And this is because of CRP binding or activating a signaling mechanism which is SRC signaling, because of which stress fibers are formed, which is confirmed by adding an inhibitor for SRC, which is PP2. Okay. I would like to highlight one more study, a new study where they try to see a novel interaction between the ductal tubes and possible blood vessels formation during acute pancreatitis. Here they try to look for a normal pancreatic SNS cells process where they try to differentiate the DNA positive ductal cells about SNL to ductal metaplasia. But in this study they try to observe this several induced acute pancreatitis is associated with pathological angiogenesis, where they try to induce APA by injecting serine and look for CD19 positive cells where it is higher, and they also observe more about CD31 positive cells in large literature, which try to wrap around the CD19 positive cells over here. Okay. The same thing is also observed in transgenic mice. Not know that it is not because of immunofluorescence that we are seeing in the blood. It's actually the endothelial cells, the vasculature, which is actually wrapping the cells over here. And they also try to do the sequencing. They have done sequence analysis sequencing, taking different components of pancreas and they have done the sequence. And they try to connect the inflammatory response, the connection between inflammasome and endothelial cells. And they identified a pathway which is positive bonding from the ductal cell is interacting with integrin alpha 5 on the endothelial cells that are being formed, and which is again they are trying to confirm with the 161 specific antagonist. When we are using it in this model, it is completely alleviating APP. So to conclude, we can use the endothelial markers to as a potential predictor indicator for patients with acute pancreatitis. And of course, deeper understanding of endothelial activation and inflammation in AP will lead to novel biomarkers as well as novel therapeutic agents. And there are also one more aspect, which is circular endothelial cells or endothelial progenitor cells, which could also be used as markers towards conditions like acute pancreatitis. With this, I'll stop. Thank you.
Actually, you mentioned alpha 5 is, so are there any other subunits like beta 5, beta 1, or it's general one? Alpha 5 is.
No, this is in the study they focused on integrin alpha 5 because the substrate ligand for the alpha 5 is SP1, which is osteopontin that they have identified. So they are not focused on other integrins over here.
No, alpha 5, but other subunits I'm talking about. Subunits, there are beta 5, beta 1, multiple other subunits. Because particularly what happens in some certain cancers, alpha 5 beta 1 is overexpressed.
Okay.
So whether is that any similar to this observation? I just want to understand from that one.
I'll check it because I'm not sure about the subunit that they have mentioned over here.
Thank you.